Welcome to Periodontics 1. In this course, you will build your foundational knowledge in periodontics. In this first module, we will look at the macroscopic, microscopic, and radiographic appearance of various tissues. So let's begin. The periodontium is composed of four very unique tissues: the gingiva, cementum, alveolar bone, and periodontal ligament. In this module, we are focusing on the gingiva and periodontal ligament. In an upcoming module, we will review cementum and alveolar bone. There are some terms we need to define before going forward. I have posted a document in your files section of Canvas so that you can follow along with this discussion. Let's first describe, beginning at the top left, the alveolar mucosa. This is defined as mucosa covering the basal part of the alveolar process and continuing without demarcation into the vestibular fornix and the floor of the mouth. A key point is it's loosely attached to the periosteum and movable. Next, let's define mucogingival junction. The mucogingival junction is the dividing line between the gingiva and the alveolar mucosa. Think of it as the demarcation between a keratinized and non-keratinized tissue, terms we will define in upcoming slides. Next, we have the attached and free gingiva. Attached gingiva extends from the coronal extent of the junctional epithelium to the mucogingival junction and is firmly attached to the underlying alveolar bone. It is also attached to cementum by connective tissue fibers, and it often presents a surface feature known as stippling, which is akin to an orange peel type of appearance. The free gingiva extends from the crest of the gingival margin to the coronal extent of the junctional epithelium and comprises gingival tissue at the vestibular and palatal or lingual aspects of the teeth and interdental papilla. Finally, we have the interdental gingiva, which is keratinized tissue that extends between the teeth. The interdental gingiva occupies the gingival embrasure, which is the interproximal space beneath the area of tooth contact. The interdental gingiva can be pyramidal in shape, or it can have a tent-like shape in posterior teeth, something that's referred to as a coal. From a macroscopic perspective, you see a few terms we have already defined. At this time, I'd like to introduce the term sulcus, which is the shallow crevice or space around the tooth, bounded by the surface of the tooth on one side and the epithelium lining the free margin of the gingiva on the other side. In clinically healthy gingiva, there's generally some depth to the sulcus, on average from 2 to 3 millimeters. Another new term is the marginal groove, which you see highlighted by the arrow. The marginal groove is essentially a demarcation between the free and attached gingiva. Microscopically, the epithelium lining the gingiva is supported by connective tissue. This provides the epithelium its blood supply. We'll discuss the components of the connective tissue in an upcoming slide. Also, within the mouth are three types of epithelium: oral epithelium, sulcular epithelium, and junctional epithelium. The oral, or sometimes referred to as outer epithelium, covers the gingival crest and outer surface of the marginal gingiva and the surface of the attached gingiva. On average, the oral epithelium is 0.2 to 0.3 millimeters in thickness. It is keratinized or parakeratinized, or it may present various combinations. The prevalent surface, however, is parakeratinized. The oral epithelium is composed of four layers: a stratus basale, a stratum spinosum, a stratum granulosum, and a stratum corneum. We'll look at these in a little more detail in a following slide. Turnover of these cells occurs every 10 to 12 days. The sulcular epithelium lines the gingival sulcus and is a thin, non-keratinized, stratified squamous epithelium without reedy pegs, and it extends from the coronal limit of the junctional epithelium to the crest of the gingival margin. The junctional epithelium is a fine, band-like type of structure which forms a collar around each tooth. is composed of stratified squamous non-keratinizing epithelium. It is usually 3 to 4 layers thick in early life, but the number of layers increases with age to 10 or even 20 layers. In addition, the junctional epithelium tapers from its coronal end, which may be 10 to 29 cells wide, to 1 or 2 cells wide at its apical termination. This apical termination is located at the cemento-enamel junction in healthy tissue. These cells can be grouped into 2 strata: the basal layer, which faces the connective tissue, and the suprabasal layer that extends to the tooth surface. The length of the junctional epithelium ranges from 0.25 to 1.35 millimeters, and cell turnover is reported to be every 1 to 6 days. The junctional epithelium is initially formed by the confluence of the oral epithelium and the reduced enamel epithelium during tooth eruption. However, the reduced enamel epithelium is not essential for its formation. In fact, the junctional epithelium is completely restored after pocket elimination surgery or when it forms around an implant. The main function of the gingival epithelium is to provide protection to underlying structures while interacting with the oral environment. This is achieved through proliferation and differentiation of keratinocytes, the principal cell type of the gingival epithelium. Proliferation of keratinocytes takes place by mitosis in the basal layer and less frequently in the suprabasal layers, in which a small portion of cells remains as a proliferative compartment while a larger number begin to migrate to the surface. The diagram representations you see here, you can see the 4 layers that we described earlier: the stratum basale, the stratum spinosum, the stratum granulosum, and the stratum corneum. Differentiation involves the process of keratinization, which consists of progressions of biochemical and morphologic events that occur in the cell as they migrate from the basal layer. The main morphologic changes include the following: a progressive flattening of cells as you go from the basal layer to the surface, an increased presence of tonofilaments, the couple of intracellular junctions with the production of keratohyalin granules, and the disappearance of the nucleus. Again, keratinized epithelium, as you see on the left, composed of 4 layers: the stratum basale, which is the basal layer of cuboidal cells along the basement membrane, is the site of cell replication and manifests a full complement of organelles. Next is the stratum spinosum, which is referred to as the spinous or prickle cell layer. It is called this because of the appearance of prominent peripheral cytoplasmic processes resembling spines under a light microscope. The cytoplasm is rich in tonofilaments, which terminate in the attachment plaques of desmosomes which attach adjacent cells. Essentially, large polyhedral cells with diminished cellular activity compared to the basal layer. Langerhans cells are usually found in this layer, and mitotic figures may be observed in the lower layers. Next up is the stratum granulosum. This is referred to as the granular cell layer, characterized by the presence of keratohyalin granules, which are believed to play a role in the process of keratinization. Cells are flattened, presenting diminished organelles, pycnotic nuclei, and degenerative mitochondria. Desmosomal changes may be observed in the upper regions of this layer and are smaller and more numerous in deeper layers. The stratum corneum is the uppermost layer, which is a keratinized cell layer characterized by a flattened pycnotic cell composed of tightly packed tonofilaments. Organelles are rare, and keratinization may be associated with cell lysis. Continual degradation of desmosomal attachments eventually results in loss of keratinocytes on the epithelial surface. Non-keratinized epithelium does not have the top 2 layers, as you see here on the right. It is missing the stratum granulosum and stratum corneum. Here we have a picture of non-keratinized and keratinized epithelium that have been stained with hematoxylin and eosin. You can see this distinct difference between the 2, with the stratum granulosum and stratum corneum missing in the non-keratinized layer. A complete keratinization process leads to the production of what is known as an orthokeratinized surface, which is a superficial layer similar to that of the skin, with no nuclei in the stratum corneum and a well-defined stratum granulosum. Some areas of the outer gingiva are orthokeratinized. However, the other gingival areas are covered by a parakeratinized or a non-keratinized epithelium, considered to be in an intermediate stage of keratinization. In parakeratinized epithelium, as we see on the right, the stratum corneum retains pycnotic nuclei, as you can see in the upper layer. Keratohyalin granules are dispersed rather than giving rise to a stratum granulosum. Other cells are found in the epithelium and can include clear cells or non-keratinocytes, which include the Langerhans cells, the Merkel cells, and the melanocytes. Melanocytes secrete melanin are found in the lower layers of the epithelium. Between individuals, the number of melanocytes are constant, but the amount of melanin production and phagocytized by adjacent keratinocytes is what determines the variation in pigmentation. Melanocytes are derived from neurocrest precursors. Langerhans cells are essentially dendritic-shaped cells believed to be part of the immune surveillance system. Their numbers increase in inflamed tissue by 2 to 10 times, with cells probably migrating from the underlying connective tissue in response to an antigenic challenge. It is postulated that the role of Langerhans cells is in the uptake and presentation of antigen to T cells, possibly constituting one of the first lines of defense against surface penetration of the host by forcing antigens. Langerhans cells are thought to be derived from progenitor cells in the bone marrow. Merkel cells are non-dendritic clear cells situated in the basal layers in the oral epithelium. They have sparse tonofilaments and are often associated with nerve fibers and are thought to act as touch sensory cells. Next, we need a way for these epithelial cells to adhere to each other. Keratinocytes are connected to one another by a particular feature called a desmosome. Desmosomes constitute the most common cell junction, consisting of the outer leaflets of cell membrane of 2 adjoining cells. Hemidesmosomes, as represented here, are considered to be half of the desmosome and form the attachment of epithelial cells to a basement membrane. Gap junctions represent cell communication channels, as you can see here. These channels are lost in areas of moderate inflammation. In addition to these structures, there are others known as tight junctions, which function in ion exchange, compartmentalization, and cell adhesion. The connective tissue is quite complex and consists of cells, fibers, ground substance, and blood vessels and nerves. Cells represent about 5% of the overall connective tissue, with fibroblasts making up 65% of that total. Also can be found here are mast cells, PMNs, macrophages, lymphocytes, and plasma cells. Fibers are mainly collagen that are found here and comprise about 60% of the connective tissue. Reticular and elastic fibers can also be present within the connective tissue. The ground substance represents 35% of the connective tissue and typically consists of 2 protein polysaccharide macromolecules made up of proteoglycans and glycoproteins. The proteoglycans contain glycosaminoglycans as the polysaccharide units, which are covalently bonded to one or more protein chains. These are usually very large molecules that occupy most of the ground substance and function to regulate diffusion and fluid flow through the matrix and as molecular filters. Glycoproteins are unique in that they function in cell-to-cell and cell matrix interactions. Fibronectin is the principal glycoprotein in connective tissue, serving to orient fibroblasts to collagen and provide protein attachment for cell matrix adhesions. Fibronectin may influence the migration of fibroblasts and play a crucial role in maintaining structural integrity of the connective tissue. Also within this glycoprotein group is laminin, which is an attachment glycoprotein for epithelial cells mediating the attachment of these cells to the basement membrane. Laminin preferentially binds to type 4 collagen. The connective tissue component of the dentogingival unit contains densely packed collagen fiber bundles, which are a mixture of type 1 and 3 collagen fibers and are arranged in distinct patterns that maintain the functional integrity of the tissues and the tight adaptation of the soft tissues to the teeth. These include dentogingival fibers, which are fibers which extend from the supraalveolar cementum of the tooth and spread out in a fan-like fashion into the free gingiva. Circular fibers are also present and are represented here on this diagram. Circular fibers course through the free gingiva, encircling the tooth in a ring-like manner. Some fibers insert to bone and cementum. Dentoperiosteal fibers, represented by the letter B in the diagram, actually extend from the supraalveolar cementum, coursing apically over the facial and lingual bone, and terminate in the attached gingiva. Transeptal fibers, represented by the letter H, extend from tooth to tooth between teeth and are connected to the supraalveolar cementum of the individual teeth. Alveolo-gingival fibers, represented by the letter C, are fibers that extend from the periosteum of the alveolar crest coronally into the gingiva. So how does the tooth attach to the surrounding bone? This is the function of the periodontal ligament, also referred to as the PDL. The periodontal ligament is composed of a complex vascular and highly cellular connective tissue that surrounds the tooth root and connects it to the inner wall of the alveolar bone. It is continuous with the connective tissue of the gingiva, and it communicates with the marrow spaces through vascular channels in the bone. Although the average width of the periodontal ligament space is documented to be about 0.2 millimeters, considerable variation exists. The periodontal ligament has its own unique fiber groups that are present. At the coronalmost extent of the periodontal ligament, you will find fibers that are termed the alveolar crest fiber group. As we begin to progress apically, we will have fibers that are horizontal, oblique, and then at the apical region, and then in the radicular region. The periodontal fiber groups are basically classified based upon their orientation. Radiographically, the PDL represents itself as a dark line paralleling to the root, as represented by the large blue arrow. It appears thinner around teeth that are not in function and in unerupted teeth, but it is increased in size in teeth that have been subject to hyperfunction, known as trauma from occlusion. Finally, let's examine the blood supply to the gingiva. There are essentially three sources that nourish the gingiva. Periodontal ligament vessels, represented by figure 1, which extend into the free gingiva and gingival branches derived from intraalveolar arteries, which also proceed into the gingiva. Next, as represented by the number 2, are intraalveolar arteries, or intraalveolar vessels, which course through the bone and anastomose with supraperiosteal vessels and periodontal ligament vessels. Last, as represented by the number 3, are supraperiosteal vessels, which originate from the lingual, mental, buccal, infraorbital, facial, posterior superior alveolar, and palatine arteries. In the blow-up of the diagram, you can see that there are many loops that are formed. These terminal branches of each of the three arterial sources form numerous anastomoses and capillary loops. These arterial loops are especially prominent within the connective tissue that interdigitates with the oral gingival epithelium. This concludes our look at the gingiva and periodontal ligament.